Hi everyone, and in this video, I'll be starting the first topic of pharmacology, that is pharmacokinetics. So, what is pharmacokinetics? Pharmacokinetics means two words. Pharma means drug, kinetics means movement of the drug. Now, it is simply understanding what our body does to the drug. What can it do when we take the drug? The drug will be absorbed, distributed, metabolized, and excreted. So we'll go one by one. We'll understand what is absorption, what is distribution, how the drug is metabolized, how the drug is excreted. So how to understand pharmacokinetics? We will take a simple example. We take an example of paracetamol. So we'll try to take paracetamol and understand what happens to the paracetamol when it is taken orally. So let us start our journey. Pharmacokinetics. Yes. So the name is pharmacokinetics. I told you it is two words. So pharma means drug and kinetics means movement of the drug. So kinetics stands for movement of the drug. So you can also call it as what body does to the drug. So pharmacokinetics is also called as what the body does to the drug. Now what can the body do? There are four things I told you. One is the A, one is the D, and one is the M, and the fourth one is E. So what is that? So A stands for the absorption of the drug. And what is D for? D for distribution of the drug. Sir, what is M for? Metabolism. It is the drug metabolism. And what is E for? Throwing the drug out of the body, that is called absorption. So whenever we think of pharmacokinetics, the four letters has to come to your mind. The absorption, distribution, metabolism, and excretion. These are the four important things. Sir, how do we understand this pharmacokinetics? Simply remember, what is the standard drug given for fever? Paracetamol. Now let us understand when we take paracetamol orally. So how do you take a tablet? We take a bit of water, then the tablet and full glass of water. So when we take that, it will go through the esophagus, stomach, intestine, and from the intestine it is absorbed. Then it will go to the heart. It is distributed from the heart to the site of action. Then it is metabolized and excreted out. So let us understand with a simple example of paracetamol. So let us take the example of tablet paracetamol, and with that we'll learn what happens to the drug when it is taken. So let me take the example of paracetamol 500 mg. Now when the drug is taken, it moves through the esophagus, then this is the stomach, and this is the intestine. This is the intestine. Then we have the liver here, liver, and then the heart. Once you know the heart, we have the blood vessel here. This is the blood vessel. This is the blood vessel, right? And then the other organs of elimination like the kidneys. This is the kidney. Yeah. So I need these organs to make you understand. Now let us trace. When the tablet paracetamol is taken, the drug will enter. So when the person swallows it, it will enter. The first question is, will the tablet get absorbed like tablet only? No. First it has to become like powder. So that is the reason it is called as disintegration. So the first thing is the tablet has to disintegrate. Right. Once it is disintegrated, it has to dissolve. So the next thing is the drug undergoes dissolution. Now that is the reason why we give solution in a kid or a child, because it's easy to get absorbed because already it is dissolved. Now once the drug comes to the small intestine, so the first thing that happens is from the small intestine the drug gets absorbed into the systemic circulation. That is, the first thing is absorption. So the drug is absorbed. Now once the drug is absorbed, it reaches the liver. From the liver, it reaches the heart. So it reaches the heart here. Now once it reaches the heart, let me trace here. So from the liver, it reaches the heart. Now the heart is the organ which pumps and supplies everyone, because from the heart the blood vessel originates and everywhere the drug is distributed. So the next step is the drug distribution. So the next step is drug distribution. So how does it get distributed? So when the drug reaches the blood vessel, it has to get distributed. Now we are taking the example of paracetamol. So paracetamol has to go and work. The site of action of paracetamol to decrease the fever is in the brain. So in the brain, it goes and decreases the fever. So the drug paracetamol enters the brain and decreases the fever. Now this decrease in fever is, we have a separate branch for that, and that is called pharmacodynamics. Sir, what is pharmacodynamics? We will study it detail in the next videos. Pharmacodynamics is nothing but what the drug does to the body. So what does paracetamol did? It decreased the fever. The question here is, if I take one paracetamol, will it remain in the brain forever? It's good only, right? One tablet of paracetamol stays in the brain forever. No need to take it again and again. Fever will always be controlled. Imagine one tablet of sleeping tablet and you are sleeping forever. So it will not happen. So once the drug has produced the action, it has to again come back. Certain times what happens when the drug has gone out, sometimes it is stored in the tissue. So it will undergo tissue storage. So in certain tissue, it will be there for a very long period and comes out from this very, very slow. Now you tell me, if the drug is stored in the tissues, will it be long acting or short acting? Usually it is longer acting. And second problem is, if they are stored in the tissues for very long, there is a chance of adverse effect. Okay, let us discuss that later. So once the drug is done the action, it will come out. So once the drug comes out, the body will not keep the drug inside. Why? Whatever drug we are giving, they are all chemicals and they are all xeno. Xeno means foreign to the body, and the body doesn't want to keep it. So what the drug will be going next is to get metabolized, because the body wants to throw it. So the next step what happens is the drug metabolism. So the drug metabolism. So once the drug is metabolized, now it is to be thrown out from the body, and that process is called excretion. And that process is called drug excretion. So the major site for excreting a drug is kidney, that is through the urine, or sometimes it can be thrown out with the help of the bile. So in the bile also it can be excreted out. So penultimately, this is what we are going to study in the future videos: the drug absorption, drug distribution, then drug metabolism, and drug excretion. So this is what is the meaning of pharmacokinetics, what the body does to the drug: absorbs, distributes, metabolizes, and excretes. But what the drug does to the body is what is a field by the name pharmacodynamics, which we will discuss later. So we'll go one by one now. So I'll be discussing one by one. The first factor is called the drug absorption. So the first factor what we are going to discuss is the drug absorption. Sir, what do you mean by that? The meaning is simple. The drug absorption is, we give the drugs by various routes. So there are various routes of drug administration. So there are various routes of drug administration. So now we gave it by oral route, that is the route of administration. From various routes, so these are the various routes. From various routes, the drug has to reach the blood vessel. So this is the blood vessel. From various route, the drug has to reach the blood vessel. And in simple terms, we call that reaching this blood vessel as reaching systemic circulation. Reaching systemic circulation. So absorption is nothing but from the route of administration, it has to reach the systemic circulation, but in between we have a process which will help in this absorption, and they are called drug transport mechanism. So there are certain drug transport mechanisms which will help in the absorption. Clear? So usually what is the most common mechanism is the drug will move from high concentration to low concentration. The drug will move from high concentration to low concentration. And what are the routes? You know that oral route, sublingual route, we'll discuss that later. Now, what are the drug transport mechanisms we have? Drug transport mechanisms, you have studied in physiology. It's just a recap of this. What are the drug transport mechanism we know of? Now, we have the passive transport as well as the active transport. You know the meaning of passive? No energy or no ATP is required for this. And as the name tells active, it requires the energy ATP. Now passive transport are two important aspects. It is nothing but the simple diffusion. So it is the simple diffusion, and one more is called facilitated diffusion. Okay, so we know this in physiology. I'm just a recap for this. So what is simple diffusion? It's nothing but movement of the drug from high concentration to low concentration. That's it. So the drug will move from high concentration to the low concentration of the drug. So that is called simple diffusion. Facilitated diffusion requires a carrier. So it is a carrier mediated transport. And most of you know the example for this. The example for this is the glucose transporter, that is GLUT. So that is the example. Now coming to the active transport. Active transport, we have two variants. The symport. Symport means same direction. Antiport means different direction. You know that? So symport, the name itself is starting with same. They both go in the same direction. Example for symport is sodium glucose transporter. So SGLT1 and 2. So sodium and glucose, they move in the same direction. Antiport we have a certain called H plus K plus ATPase. So H plus K plus ATPase, because H plus moves outside, potassium moves inside. One more is sodium potassium ATPase. So here also potassium moves inside, sodium goes out. So these are all your correlation with physiology. But remember, in all this aspect, what is the most common method of drug absorption? If they ask you, it is simple diffusion. Please mark this. Now, what is the most common mode of drug absorption in all these transport mechanisms? Yes, if they ask you this, the answer should be very good. It is the simple diffusion. Simple diffusion. So that should be your answer. Okay. Now there are other ways of drug absorption. Example is endocytosis. So the drugs can get undersized if they are bigger inside. For example, the absorption of vitamin B12, or there is a process called pinocytosis. So it is for the liposomal anti-cancer drugs. So liposomal anti-cancer drugs. So these are the other methods of drug absorption, but whatever it is the most common is simple diffusion. You may ask a question, sir, we understood that, sir. Now, if you have understood that, let me draw the intestine. So we are tracing the paracetamol here. Let me draw the intestine. This is the intestine. Now in the intestine, we have the cells of intestine. These are the cells. So these are the cells, right? So I have written these cells for you. Yeah. Now there are two important properties of the drug. The drugs may be lipid soluble. So the drugs are chemicals. So obviously when they are chemicals, there should be either lipid soluble drug or they should be water soluble drugs. Now these lipid soluble drugs are also called by one more name, non-ionized. So they are also called as non-ionized drugs. And what is water soluble also called as? They are also called as ionized drugs. Now you have to tell me who can cross the membrane easily. You pause the video and just answer. Who can easily diffuse? Yes, obviously the lipid soluble drug can easily cross the membrane. They can easily cross membrane. Now water soluble drugs cannot easily cross the membrane. They are not able to cross unless they are very small in size. For example, I'll give an example of a water soluble drug called ethanol and lithium. Now these are water soluble, but the size of the drugs are very small. Now if the drug size is very small, there is a space between the cell. Can you observe this? The intercellular space, this is the place where they can get inside the circulation. So water soluble drugs can go through that, but very, very difficult because it's a very small space. So water soluble drugs are not going to cross easily inside. And in fact, water soluble drugs are easy to clear from our body. So these are easily cleared out of our body. But still the water soluble drugs are absorbed because we have other transport mechanism. You have seen active transport, that symport, antiport and carrier mediated transport, all those will take this inside. But lipid soluble drugs, they have the privilege because the cell membrane is made up of lipid. They are lipid soluble, so they can easily diffuse and they can enter. So this is what we mean by the drug going from high concentration to low concentration, that is simple diffusion. Okay, so this is the basic we understood in the drug transport mechanism. So once we have understood the mechanism of drug transport, let us understand how can we administer the drug. So let us understand the routes of drug administration. Routes of drug administration. Now we are discussing currently the oral route. Apart from that, what are the other routes we know of? Now basically the routes are two types. So the systemic route and the local route. So we have the systemic route and local route. You may ask a question, what is systemic route? Systemic route is nothing but when I give the drug will go from there and it will distribute everywhere. So the drug, for example, if I am taking paracetamol, it will not stay only in the oral route or it will not stay in the intestine, it will go everywhere. It can also reach the brain. Suppose if I put an eye drop, the eye drop remains only in the eye. Or if I give a drug into the joint, it will stay there only. So that is called local route. Systemic route means the drug reaches everywhere, usually everywhere. So it will go to the blood vessel and it gets distributed. Local route means it acts locally where it is given. Where it is given. Sir, will the local route get systemically absorbed? There is a chance. But local means the drug acts where it is given. Systemic means when you are given the drug, from there it goes everywhere. It reaches the blood vessel, it will get distributed. Now, systemic route, there are two important things you need to note down. Systemic route has two important routes. What are those? They are called as the antral route and one more is called the parentral routes. Parentral route. Okay, sir, fine. What is entrum? Entrum means anything related to GIT. So entrum means anything related to GIT is called entrum. So whatever drugs we give through that route is enteral route. For example, we are discussing currently the oral route. So the oral is the one, then the rectal route, and one more sublingual route. Sublingual route. Now, what is sublingual? We keep the drug below the tongue. So some books give it as parenteral. Remember, the meaning of enteral means anything it is given from the oral, that is mouth to anus. Anywhere if you give in the GIT, it is the enteral route. So that's why sublingual is coming under enteral route. And one more is a route called transbuccal route. So same thing. Transbuccal, we keep it in the buccal cavity. That's it. Now parenteral, you read the name. Par means beyond. Par means beyond. Beyond what? Entrum. So it is not reaching the GAT at all. So these are called parenteral route, and we have two types in that. So parenteral means beyond intestine. So in that we have two important classifications. Now we give the drugs using injections because we have to penetrate deeply. So injection and non-injections. So what are the routes through which we give an injection? Obviously, most of you know the intravenous. IV stands for intravenous. And then one more is intramuscular. Then the subcutaneous. And one more is intradermal. Very, very important. So these are the drugs and the routes through which we give, and they are given with the help of a syringe or the injection. Now another important route nowadays very much trending is intraosseous route. Now many a times we may not get an IV line and then we use this intraosseous route. The question here is, I'll give an example. Now this is the bone. This is one more bone. So you know that junction between the bone is joint. Now if I give the injection here, that is A, or if I give the injection here B, now you pause the video and tell me A and B, which one is intraosseous? If you're telling A, that is fine. This is intraosseous because we are giving it to the bone marrow. What is B then? It is called intraarticular. So intraarticular means we are giving into the joint space. Intraarticular is a local route, not a systemic route. I will discuss it later. So I had to tell you this point. That's why I'm comparing here. I hope you are clear with this. So A is intraosseous. So the drugs which are not used by injections, non-injectables, routes are the transdermal patch. So we apply the transdermal patch. The route is called transdermal. Then we have inhalation. Which are parenteral routes. So this is what the classification is. Enteral, parenteral. Enteral we have oral, rectal, sublingual and transbuccal. Parenteral we have the injections and non-injections. So these are the classification. Now once we know this, let us understand what about local routes. Local. So I told you what is local. The drug acts locally where it is given. There are two important classes in that. What are those? Now, the drugs which are given topical. Example of topical route is the drops eye, ear and nasal drops. So these are the topical one. So we apply that topically. Or the drugs applied on skin and mucous membrane. Many a times the drugs can also get absorbed from skin and mucous membrane, but the purpose of giving, sir, for example, ointment, gels are for local action. So the topical routes are nothing but the application of the drug in the local areas, that is eye, ear, nasal drops, applied on skin and mucous membrane. Now, another important thing in this is in the deeper tissues. So the drugs given in deeper tissues, what are those? For example, if I am giving intrathecal, if I give a drug intrathecal, sir, what do you mean by intrathecal? We give the drug into the spinal cord. So the purpose of giving drug in spinal cord is for local anesthesia. So we want the drug to work locally. So intrathecal means into the spinal cord. Then just now I told you we have intra-articular, where we give it in the joint space. We give the drug into joint space. And then intra-arterial. So intra-arterial, usually we don't take the artery for giving IV fluids and all. Why? Number one, arteries are deep inside. Number two, the pressure inside the artery is so high, when you try to puncture it, the blood will come out. So deeper, and it is very difficult to assess. So if I want to use it, we use it as local route to deliver certain anti-cancer drug locally to the tumor. Or you want to do an angiography of the coronaries, locally we give it. Otherwise, it is an intra-arterial route, is a local route, and it mainly acts locally, right? So these are the important aspects you need to understand about routes of drug administration. I have told you this clarified. I have clarified this to you. Now, many times what happens, some of the routes overlap. They can be local or systemic depending on the drug also. So let me give an example for that. Let me give an example. The nasal route. Now, nasal route, it can be a local route depending on the drug. Suppose you have running nose and you use a nasal drop topically. So the nasal drop for running nose act locally and constrict the blood vessels. But same thing if you are giving a spray, intranasal spray, it acts as systemic. Example for that systemic is the spray used as the desmopressin nasal spray. So the desmopressin nasal spray. So when you spray that, the blood vessels in the nose will absorb the drug desmopressin and it will be distributed everywhere. So it's not only important, some of the route can act like this. So basically you need to understand what is systemic. That means the drug can go everywhere, absorb to the blood vessel and distribute everywhere. Local meaning the drug acts where it is given. But many times locally if you give also, some of the drugs can go to systemic circulation also and get distributed. But basic term to understand is systemic means it goes everywhere, local means it stays where it is given locally. That's the important concept you need to remember. Okay, so that is about the routes of drug administration. So once we are thorough with these routes of drug administration, let us understand what factors affect the drug absorption. So when we take the drug, what are the factors which affect the drug absorption? Let us start our journey now. So the factors affecting drug absorption. Factors affecting drug absorption. Yes. So what are the factors? Let us start our journey now. So number one, the chemical nature of the drug. The chemical nature of the drug. Sir, what do you mean by that? The meaning is, you know that almost all the drugs are chemicals only. Either they exist at weak acid or they exist as weak bases. So we cannot give strongly acid drugs because they will burn. So we can give weak acid or weak base, and strong acids are not at all absorbed. Classical example for weak acid is, you know this drug already, aspirin. So what is the other name for aspirin? Acetyl salicylic acid. The name itself is telling you it's acid. Second, we have barbituric acid, or we call it as barbiturates, barbituric acid. Then the antibiotics such as penicillins and cephalosporins. And then we have the diuretics like loop diuretics and thiazide diuretics. So don't worry about the example currently now. You are still learning the things. What I want you all to remember is the aspirin and barbituric acid, which are most important. Weekly basic drugs, example is a drug by the name atropine. Atropine. Remember, these drugs usually end with INE. It's not a general rule. Usually they end with INE. Then a drug by the name morphine. It also ends with INE, and amphetamine. Okay, so these are weekly basic drugs. Okay, sir, they are acid or base. Why are we learning this? What is the purpose of you teaching us? Let me tell you that. Now, the purpose of understanding is, now if you are keeping a acidic drug, in the acidic medium, so if you are placing a acidic drug in the acidic medium, what is going to happen is the drug is going to be lipid soluble. And what is lipid soluble meaning? The drug is non-ionized. So you tell me, I have taught this already. If the drug is lipid soluble, will it cross the membrane easily? Yes, it can cross membrane easily. Okay, sir, correct. Now, if it crosses membrane easily, what happens to absorption? There is increase in absorption. You all agree with that? Yes. So acidic drug in acidic medium, it is lipid soluble, cross membrane easily, and increase absorption. Simple thing is, if the drug and medium are same, the drug is absorbed. Now another important aspect is, if you place a basic drug in the basic medium is also called as alkaline medium. Yes. Then the drug is lipid soluble, also called as non-ionized, and it will have the same fate, easily crosses the membrane, and it is easily absorbed. So in simple words, if the drug and medium are same, they are lipid soluble and easily absorbed. But what if the drug and medium are different? Suppose I place acidic drug in basic medium. If you do like that, what happens? Let me see that. If you place an acidic drug in the basic medium, then the drug becomes water soluble, also called as ionized. Now water soluble will not easily cross a membrane. They will not easily cross. Now what is the advantage of making a drug water soluble? Water soluble drugs are easy to throw out from the body, so they are easily cleared. Right? Simple. If you want the drug to be absorbed more and more, make it lipid soluble. If you don't want the drug to be retained in the body, make it water soluble, and that will get cleared out. So that is the point. Same thing if you are keeping a basic drug in basic medium, in acidic medium. So the same fate occurs. The drug becomes water soluble, easily cleared, and not easily absorbed. So these are the things. Simple aspect. Drug and medium are same, lipid soluble. Drug and medium are different, water soluble. That's it. Yeah. Now I'll ask you this concept later when I come to a concept called excretion. Until now, you keep this in your mind. Okay, so there is something called pH and pK. I'll teach you that in a separate video. Okay, there is a separate video for that, pH and pK. So once we understand this, I will ask you a question. What is that question? Now this is the stomach, this is the intestine, right? Now you have to tell me the drug is aspirin and one more drug is morphine. Now can you tell me, out of aspirin and morphine, who is absorbed from stomach and who is absorbed from intestine? Yes, can you tell me who is absorbed from stomach and who is absorbed from intestine? Yes. If you are thinking aspirin is absorbed from the stomach, you are right, because the pH in the stomach is acidic. Aspirin is acidic drug, so it is absorbed there. The pH of the intestine is slightly basic, and the drug morphine is basic, so they become lipid soluble and easily absorbed. So this is the application. So aspirin is absorbed from stomach and morphine from intestine. You know the basics for that. Yeah. So the first factor we understood, that is the chemical nature of the drug. So once I know the chemical nature of the drug, second important thing is the food factor. So whenever we give the drug orally, the food interferes. Now, can you tell me certain drugs which are given before food? Which are usually given before food? Yes. Examples are the PPA. PPA stands for the proton pump inhibitors like pantoprazole, lansoprazole, and a hormone called levothyroxine. They are given before food. Okay, sir. The reason is food may interfere with their absorption, so they are given usually before food. Now, certain drugs, if you give them with food, the absorption increases. So, fatty food increase absorption of certain drugs. Fatty food increase absorption of certain drugs. What are the examples for this? Example is an antimalarial drug called lumefantrine. Lumefantrine. An antifungal drug called griseofulvin. And a TB drug called bedaquiline. And we have another drug which is used in HIV. It is called efavirenz. Now, efavirenz, you should not give it food. Why? If you give it food, absorption increases. When more drug is absorbed, what is the drug level? So the drug level increases. Now, when the drug level increases, it has shown to produce more adverse effect. The adverse effect is neuropsychiatric adverse effect. Neuropsychiatric adverse effect. That means patient may have the psychosis symptoms. So neuropsychiatric symptoms may present. So here the understanding is this you should not give with food. Efavirenz should not be given with food. But others you can give with food. The absorption increases, but no problem. So this is the clinical implication what we are going to learn from this. So fatty food increases absorption in case of lumefantrine, griseofulvin, bedaquiline, and efavirenz. But one clinical application, when you prescribe efavirenz, you should not give it with food because the absorption increases, drug level increases, the adverse effect increases. That's the point. So we understood before food, we understood fatty food, and then there is some other interactions. What is that? The other interactions are, you only know that, you have studied it already. Can we give iron with vitamin C? What is vitamin C? It is nothing but the ascorbic acid. Now there are two forms of iron, Fe3 plus and Fe2 plus. Now Fe2 plus is the ferrous form which is getting absorbed. Now the Fe3 plus will become Fe2 plus only in the presence of acidic environment. So it requires acidic environment to make it ferrous, and this gets absorbed. Okay, sir, fine. Now if I am adding vitamin C, it's an acid, it makes the environment acidic. So what happens to the iron absorption? Increases. So this combination is good, and that is what we mean by drug interaction. Now suppose if I am using a drug called PPA. PPA stands for the proton pump inhibitors. They make this environment alkaline. So if I give PPA with iron, is it correct? No. What happens if I combine PPA with iron? There is decreased iron absorption. There is decrease in iron absorption. So these are the interactions, food interaction you have to keep in your mind. Iron plus vitamin C is correct, but iron with PPA should not be used. Okay, sir, we understood the factors before food, fatty food, and iron. Is there anything else? Yes, I want to mention one more. Now, many times people drink milk and we prescribe an antibiotic called tetracycline. So, when we give tetracycline plus milk, now you know that major ion in the milk is calcium. So, when we give tetracycline and milk together, suppose I prescribe tetracycline and patient took milk with that, what happens? Tetracycline and calcium will form a complex. Now, if they form complex, they are big in size. If the size is big, they cannot be absorbed. So, this will lead to decrease in absorption of tetracycline. Decrease in absorption of tetracyclines. So, the message here is don't combine tetracycline with milk. That's the message. Don't combine that. So, I told you so many routes of administration, IV, IO, or whatever. Now, can you tell me which route has most variable absorption? Person to person, the absorption is variable. If you are thinking of oral, you are 100% correct. Oral route has most variable absorption because it depends on the GAT factor, the food factor, and along with that, we take other drugs also. So, please make this point. The most variable absorption is seen with most variable absorption is seen with oral route. So we see it with oral route. We are discussing the factors affecting drug absorption. So we have done with chemical factor. Second one is we are done with food factor. What is the third factor which affect that? The third important factor which affect that is the area of absorbing surface. Area of absorbing surface. Obviously, if the area is more, absorption is also more. You take the example of a cloth. If you want to, the water is spilled out, and if you want to clean that, you take the cloth and you try to do that. You cannot remove so much of water. Or you take the sponge. Sponge will absorb more because the surface area is more. So more the surface area, more is the absorption. So remember, if the area increases, the absorption also increases. So directly proportional. So increase area of absorbing surface, more the absorption. In the GAT, tell me where the surface area is more, small intestine. So please make this point. Now irrespective, a drug is acidic or basic. Irrespective a drug is acidic or basic, maximum absorption occurs in small intestine. So when you give the drug, the maximum absorption occurs in small intestine. The reason is simple. The surface area is big. Sir, just now you told the aspirin gets absorbed in the stomach. Yes, it gets absorbed in the stomach, but maximum absorption occurs in the upper part of the duodenum because even the absorption may be slower, but it gets absorbed. Maximum absorption is in the small intestine because of the large surface area. So generally, absorption occurs in the stomach, but if they ask you maximally absorbed, either it is acidic or basic, it is in the small intestine because of the large surface area. Now, another important point is, will a drug get absorbed from large intestine? I will repeat a question. Will a drug get absorbed from large intestine? Think and tell me. Yes, the drug also get absorbed from large intestine. Example is rectal route. What is rectum? Is a part of large intestine, so it gets absorbed. So drugs are also absorbed from large intestine, but not as much as in the small intestine. Correct. So that is the third factor. We are done with the third factor. Now let us move on to the fourth factor. Now the fourth factor is the blood flow. Blood flow to absorbing area. Blood flow to absorbing area. Now obviously if you increase the blood flow to that area, usually the absorption also increases. There is increase in absorption. I'll give you one example here. Now when you give an injection to the patient, immediately patient will rub that. Why he will rub that immediately after taking the injection? Because his grandfather did that, his father did that? No, there is a logic for that. When they rub that, what happens? The blood flow to that area increases. So the absorption of the drug increases, and also the pain causing substances which are present there, they are also absorbed, so pain decreases. So more the blood flow, more is the absorption. And most of you have taken COVID-19 vaccine. Did you rub it? No. Why? Because we don't want the vaccine to be absorbed faster. We want it to absorb slower. So we never rubbed it. Second important thing is when you go to a restaurant, they will give the soup in the beginning. Hot soup. Why? When you drink the hot soup in the beginning, the blood flow to the stomach increases and you will become more hungry. And that's why it is called appetizer. And when the bill comes, I know you will be more angry. But whatever, why are you studying this? I will give a classical clinical example here. Now there is a condition called anaphylactic shock. So anaphylactic shock is due to allergy. It's a type 1 hypersensitivity reaction. Now for anaphylactic shock, the drug of choice is a drug by the name adrenaline. Now we need to give this drug. There are two routes. Option is number 1 intramuscular, option 2 subcutaneous. Now you tell me, which route will you prefer? If you're telling IM, yes, you are 100% correct, because the name itself is shock. Shock means blood is not flowing in the periphery. So if I give subcutaneously, the blood flow is not that much, and if it is not that much, adrenaline is not absorbed. But in blood in the muscle is comparatively better compared to subcutaneous. So we need to give intramuscular adrenaline better than subcutaneous, so that this route is better. And that's the reason why we correlate these things clinically. So in anaphylactic shock, you have to give adrenaline IM more than subcutaneous. Clear? Yeah. Number 5, what we are going to deal in the oral route, I told you, it has most variable absorption. What happens if there is a GAD disease? Suppose we are giving a drug, patient number 1 has diarrhea and patient number 2 has constipation. Now you tell me where the absorption increases, where the absorption decreases. Obviously diarrhea, there is decrease in drug absorption. Why? The drug won't stay in the stomach or intestine, immediately will go out. Where the drug increases absorption is in a patient with constipation. So that's why the GAT factors also play a role in drug absorption. The sixth factor. What is the sixth factor? There is a protein called P-glycoprotein. So P-glycoprotein stands for permeability glycoprotein. Now what is the role of it? It's an efflux pump. It's an efflux pump. Sir, what do you mean by efflux pump? The name itself is telling you a pump which will throw something out. Sir, what does it throw out? Let us see. Now where it is present in intestine. It is present in intestine. It is present in placenta. It is present in intestine. It is present in placenta, and also it is present in blood-brain barrier. Okay, sir. But what is the role? Now let me take the example here. Now this is the intestine. This is the intestine. I am writing like this. Now what I am doing is I am enlarging an intestinal cell where the drug will move. This is the intestinal cell. Now let me take a classical example. The drug name is digoxin. Now digoxin is used in the management of congestive heart failure. We'll discuss that later. Don't worry now. Just remember there is a drug called digoxin. Digoxin, when we give, let us understand, we give 100 drugs to the patient orally. What happens? We have a P glycoprotein in the intestinal cells. It's like a watchman. Now, when I give 100 drugs, what happens? 50 will get absorbed, 50 will enter, another 50 will be thrown out by this P glycoprotein. They will go out. The nature has given this P glycoprotein so that the toxic chemicals or the xenobiotics, they should not enter our body. So when I give 100 digoxin, 50 will go, 50 will enter inside normally. So based on only, we would have given the drug to the patient. We would have given 100 thinking that 50 will go out, 50 will come in. I would have given digoxin. Yes, sir. No problem, sir. Problem is when we give digoxin with other drugs. There is a drug called clarithromycin. The drug name is clarithromycin. Now this clarithromycin is an antibiotic. Now if I combine this with digoxin, what happens? The role of clarithromycin is to inhibit this P glycoprotein. The role of clarithromycin is to inhibit P glycoprotein. Now tell me, if I am giving clarithromycin and digoxin together to a patient, what happens? Just tell me what happens. So the watchman has been blocked. Then all the 100 can enter inside. So all the 100 can enter inside. And what happens if all the 100 enters inside? There is increase in digoxin level in the circulation. What happens if the digoxin levels are increased? Obviously the adverse effect will occur. That is what we mean by toxicity will occur. So this is what we mean by the drug interaction. So point to understand is, don't combine clarithromycin and digoxin together. If I give them together, the digoxin level increases because the watchman P glycoprotein is inhibited and the toxicity can occur. Now there are certain drugs, they can induce P glycoprotein. There are certain drugs which are P glycoprotein inducers. Now what do you mean by that? These drugs increase the number of P glycoprotein. They will increase the number of watchmen. So they can throw it out. So they can throw the people out. So the example of this is rifampicin. So they had asked this question, rifampicin, then an anti-epileptic drug, carbamazepine. So these are examples of P glycoprotein inducer. One of the example I have given is inhibitor is clarithromycin. So other P glycoprotein inhibitors also I will give an example. Examples are, I have already given clarithromycin, then we have quinidine, amiodarone, then verapamil. So these are the three drugs. Now there are other drugs also. I am not going to tell you right now because you have to understand the concept first. Now this concept I will ask you again when I teach you the digoxin topic. So until that, remember, there is a P glycoprotein to protect us from the harmful chemicals. There are drugs which can also inhibit that. There are drugs which can also induce that. One important drug interaction I understood is when I give digoxin with clarithromycin, what happens? The clarithromycin inhibits that and the level of digoxin increases because more is absorbed. So that is the importance of P glycoprotein. But this P glycoprotein has one more problem. What is that? There are certain anti-cancer drugs. Now you read the term anti-cancer drug. What do you mean by that? These are the drugs which are going to kill the cancer cell. Now let me write a cancer cell. This is a cancer cell. Now what happens? These cancer cells have to survive. They have to survive. To survive, what do? They increase the synthesis of P glycoprotein. So they increase the number of P glycoprotein. So whenever we use an anti-cancer drug to kill this cell, the cells have P glycoprotein which will throw them out. So they will efflux them out. So if these drugs are effluxed out, will they work? No. So this will lead to the drug resistant or the resistance that will lead to resistance to anti-cancer drugs, resistant to anti-cancer drugs. So these P-glycoprotein are expressed by the cancer cells to protect themselves. And if they express that, the anti-cancer drugs will not work, and that is what we mean by resistance. So this is one of the mechanism by cancer cells to survive in our body. Okay, so that is about P-glycoprotein. So now, until now, we have understood certain aspect. I just want to quickly recap those things. We are dealing with pharmacokinetics, absorption, distribution, metabolism, excretion. In absorption, I told you lipid soluble can easily cross, water soluble difficult, and they can enter through other transport mechanism or through the intercellular spaces if they are very small. The most common method of drug absorption is simple diffusion. What is absorption? It is the movement of drug from route of administration to systemic circulation. What are the routes? I told you systemic and local. Systemic, we have enteral and parenteral. Local, we have the topical as well as deeper tissues. Then we discuss factor affecting drug absorption. In that, number one, the chemical nature. Drugs are either acidic or basic. Then I told you if the drug and medium are same, they are absorbed. If they are different, they are cleared out. Second, the food factor. Then third is the area. If more the area, more absorption. And then we discussed the blood flow. More the blood flow, more absorption. Then the GAT diseases, diarrhea, decrease absorption, constipation increases. And the last concept what we discussed is P-glycoprotein, which is an efflux pump, and how the drugs will vary its action. And it's also responsible for the drug resistance in cancer cells. So that is about the factors affecting drug absorption. So once we know this, let us understand a concept called bioavailability. So what is the meaning of bioavailability? Bioavailability stands for fraction of drug. Bioavailability stands for fraction of drug available for systemic action in unchanged form. Sir, what do you mean by this? Don't worry about the definition. First, we'll understand the concept, then we'll come to the definition, then it will be easier. So let us understand like this. Now, this is the esophagus. This is the stomach and the intestine. Clear? And this is the liver here. This is the liver. So when we give the drug has to get absorbed. This is the point. Now let us take the example. We have taken the example of paracetamol. Let us go with that. How much paracetamol we took the example? 500 mg. So when the patient takes 500 mg of paracetamol, 400 mg of paracetamol is absorbed. Sir, what happened to another 100 mg? It may not be absorbed. So please think that whenever you use the drug oral, not everything is absorbed. Some are not absorbed, so they are not absorbed. So 400 mg is absorbed. Okay, sir. Then it went to the liver. After the liver, it came back to the systemic circulation. So when it came here, the level of the drug is 300 milligram. Now the drug became 300 milligram. Okay, sir. There it is not absorbed. Then how come it became 300 milligram here? The reason is when the drug enters to the liver, it is metabolized. And when it is metabolized for the first time. So this is also called by the name first pass metabolism. It is also called by the name first pass metabolism. Now this metabolism is occurring before reaching the systemic circulation. So it is also called by the name pre-systemic metabolism. It is also called as pre-systemic metabolism. We'll come to that later. We'll come to the concept of first pass metabolism or pre-systemic metabolism later. Let us understand the viability. So you can read the definition now. Fraction of drug available for systemic action in unchanged form. So when I give the paracetamol oral, how much did I give? So oral viability is nothing but how much I gave? 500. I gave 500. How much is available now? 300. So this is the fraction. So 3 by 5 is the fraction available for systemic action in unchanged form. Unchanged means without any metabolism, without anything else. So without anything, it is available as such as paracetamol only. So that's the meaning of fraction of drug available for systemic action in unchanged form. So when we give 500, how much is available? 300. So the fraction is 3/5. So we don't express like this. We have to express in percentage. So we multiply it by 100. So it's around 3 by 5 into 100. It comes around 60%. So we express the viability in percentage. So the viability of this drug is 60%. Okay, sir. Now another important aspect I want to tell you. Suppose if I give the drug, this is the systemic circulation, the vein. If I give the drug directly into the vein, I took 500 mg of paracetamol and I gave all the 500 mg into the vein. So the route is called intravenous. Now tell me guys, if I give it IV, what is the viability through IV route? What is the bioavailability through IV route? Yes. So when I give the drug IV, what is the viability? Can you guess? Yes. How much did we give? 500. How much is available without any changing or without any first pass metabolism? 500 into 100, how much? So the viability is 100%. So IV is the only route which has 100% viability. It is the only route which has 100% viability. This was the question asked in your recent exam. Please mark it. That is the only route which has 100% viability. Okay, sir. Okay, sir. Okay, we got the point. Now we understood viability. But remember one more thing. Now in certain calculation, viability is written with the capital letter F. Now when they write this in capital letter F, when you are doing pharmacokinetic calculations, remember, if it is 100%, F will become 1. If it is 60%, the F value will become 0.6. This is for the calculation part. So I will teach you the calculations later, and that part you need to keep this in your mind. So for calculation purpose, if the viability is 100%, you have to tell the F value as 1. 60%, 0.6, 50%, 0.5. That's it. Easy. Okay, sir. Now once we understood that, sir, what is this first pass metabolism or pre-systemic metabolism? Now I told you there are absorption, distribution, metabolism. So first is absorption, then distribution, then metabolism. Before distribution only there is metabolism. Sir, what is the problem with this? The problem with these first pass metabolism is, the question number 1 asked is, what routes have this first pass metabolism? What are the routes which have this? Yeah, one thing we are discussing, obviously, the oral route has first pass metabolism. What about the other route? The other route which has first pass metabolism is rectal route. Now rectal route is special because it is absorbed, the drug is absorbed from the rectal route through two important veins, the internal hemorrhoidal vein and the external hemorrhoidal vein. So if it is absorbed from the internal hemorrhoidal vein, it will go to the portal vein. Portal vein will go to the liver. So it will have 50% first pass. If it is absorbing through external hemorrhoidal vein, so no first pass. Another 50% will not have first pass. So, but penultimately, rectal route also has first pass, that is 50%. Now the point here to understand is oral and rectal are the only routes which have first pass. Apart from that, any other systemic route you take, they don't have first pass. Simple. Sir, what about sublingual? Do they have first pass? No. you take the sublingual route below the tongue, the drug gets absorbed. From there, it will go to the vein and directly to the heart and get distributed. There is no liver in between. So if the liver comes in between, there is first pass metabolism. So the question is, does sublingual has first pass? No. Does IM has first pass? No. So other routes don't have first pass metabolism. That is clear. So there is only two routes which have first pass, oral and rectal route. Okay. But the point here to understand is the viability of the drug depends on two important factors. What are those? Viability depends on two factors. What are those? The absorption. Point number one, absorption. Now, how do they depend on? If absorption increases, obviously the viability also increases. So can I write directly proportional? Obviously, if more drug is absorbed, more is available. Now you tell me viability and first pass metabolism, how they are related. If drug is metabolized more in the first pass, what happens? The viability decreases. So can I write these are inversely proportional? Very, very important point. So viability is directly proportional to absorption. More is absorbed, more is viable. First pass metabolism is inversely proportional. If more is undergoing first pass, less is available. You are clear with this? Yes, we are clear with this. So viability depends on two factors. One is absorption as well as first pass. Now, why IV route has 100% viability? IV has 100% viability because it has no absorption part, and no first pass. And that's why whatever you give, everything is inside the system circulation. I'll ask you a question. Why if I am giving IM, the viability is not 100, it is less than 100%. Even IM doesn't have first pass, no first pass. Then why it doesn't have 100%? Why the drug will not be 100%? The point is here. Now when I give a drug intramuscular, the drug will be deposited in the muscle. From the muscle, it has to undergo absorption to the blood vessel. So there is some absorption process. During absorption, some of the drug may remain in the blood vessel and some are absorbed. So there is absorption in intramuscular. So there may not be complete absorption also. That's why the other routes don't have 100% viability. The only route is intravenous because it has no absorption part, it has no first pass. But what about other routes? Even though they don't have first pass, they have something called absorption. So if the absorption is decreased, the viability also decreases. That's the point. Okay, sir, we got the point. Fine. Now the next point we need to understand is there are certain drugs which have high first pass metabolism. Right. What do you mean by that? Now you take the example here. Suppose I will come back to the same diagram here. Otherwise, we will write it again. No problem. Let me write the same diagram here. So the liver here, and this is systemic circulation. Now suppose I give a drug 500 mg, and the drug coming here is only 5 milligram. That means the liver is metabolizing it too much. I given 500 mg, only 5 milligram is available. Even the drug is absorbed, it is metabolized for the first time in the liver. Examples of the drugs are drugs called nitrates. These have first pass metabolism when I give it oral. So to avoid first pass metabolism, we give the drug by sublingual route. The reason why we give it by sublingual route is because it doesn't have first pass metabolism. The question here is, please listen carefully. Suppose I want to give nitrate orally, what should I do? If I want to give it orally, what should I do? Even though I know the metabolism is there, first pass metabolism is there, but still I want to give it oral. What should I do? Think. I have to increase the dose. So if I give more dose, I have more viability. So when I am giving the drug nitrate, I will increase the dose and give it. or I'll tell it as we give it with higher dose. We'll give it with higher dose. Okay, sir, fine. Now, why these are clinically important? Why these are clinically important? Now, you know that nitrates are given during a heart attack, that is a chest pain or angina pectoris, what you will learn later. Now, we give it sublingually. It will work immediately because it has no first pass metabolism directly to the heart. Now, oral drugs, we don't give it for emergency, we give it for prophylaxis. Suppose in the emergency ward, you don't have the sublingual tablet. You didn't get the tablet. So what you got is the oral tablet. So what you did is you took the oral tablet and told the patient you chew it in the mouth so that it gets absorbed. Now tell me what will happen. What will happen? Now if the oral tablet is taken, what happens? The dose is higher, and when the patient keeps it below the tongue, the absorption is also more, the dose is more, the adverse effect is also more. So that's the reason why these are important. If the drug is designated for sublingual, give that because the dosage is lesser there. If the drug is designated for oral load, give it oral. Don't give it sublingual. If you give sublingual, it doesn't have first pass metabolism. The dosage delivered will be more and adverse effect is more. That's the reason why we learn all these things. So example is nitrate. So either we can give sublingual or we can give it oral, but the only point is make it higher dose. There are drugs called hydrocortisone and a drug by the name lignocaine. These two have high first pass metabolism, so that's the reason we don't give them oral, we give them by parenteral routes. So we give them by parenteral route. Other drugs which have this high first pass metabolism are the drug by the name propranolol, then salbutamol, and verapamil, morphine. They all have high first pass metabolism, but still we are giving them orally. Why? We are giving them orally with increasing the dose, to overcome that first pass metabolism. Sir, why can't we give hydrocortisone lignocaine orally? You can give it, but the problem is the toxic metabolites are going to cause adverse effect. So that's why these are given parenterally. So that is the importance of knowing the first pass metabolism and why IV has 100% and what is viability, and we understood all these things in this. Okay, the last question for you. What route has fast rate of absorption? Which of the following route has fast rate of absorption? Take a guess. And most of you are telling sublingual, or most of you are telling IV. Now the IV cannot be the answer because IV has no absorption. So where is the question of rate of absorption? How fast it is absorbed will not come to the picture. If you think sublingual has less surface area. Please note down the fast rate of absorption is seen with inhalation route. Lungs. The reason is when you inhale through the lung has large surface area. So I told you more the surface area, more is the absorption. That's the point. So the fast rate of absorption is seen with inhalation route. Mark it. Okay, so let me summarize these things. Pharmacokinetics means we understand what the body does to the drug: absorption, distribution, metabolism, and excretion. Then we understood what is drug absorption is nothing but from route of administration to systemic circulation. There is a transport process called simple diffusion, then facilitated diffusion, active transport, we have symport, antiport. The most common method of drug absorption is simple diffusion. Now, lipid soluble drugs can easily get absorbed. Water soluble drugs are easily cleared out. They can also get absorbed, but not so easily, but they are easily cleared out. Then the factors affecting absorption are, the important one is chemical nature. If you are placing the drug and the medium are same, the drug is lipid soluble, absorbed. If the drug and medium are different, the drug is water soluble, it is easily cleared out. The second factor is important, the food factor. Then the area. If the area is more, absorption is more. If the blood flow is more, the absorption is more. Irrespective whether the drug is acidic or basic, the maximum absorption occurs in small intestine because of large surface area. Then we have a protein called P-glycoprotein, which is an efflux pump, and I told you the drug interactions there. And then GIT factor also absorption is affected there. Diarrhea decreases absorption, constipation increases, and the most variable absorption is seen with oral route. Then we discussed bioavailability. Bioavailability is nothing but what is the fraction available for systemic action in unchanged form. Bioavailability depends on two factors: absorption. If more absorption, more bioavailability, and first pass metabolism. If there is more first pass, less bioavailability. There are certain drugs which have high first pass metabolism, and those drugs are given parenterally, but if you want to give them orally, you have to give them with higher dose. The route which has 100% bioavailability is IV route because it has no absorption part, no first pass metabolism. Now there are only two routes which have first pass metabolism. One is oral and one more is rectal route. Right? Sublingual doesn't have IM, IV doesn't have. Sir, why only IV has 100%? Because other routes, they don't have first pass, but they have the part called absorption. So absorption may be delayed there. Okay, so what is the fastest absorption route? Is inhalation route. So these are the things what we understood in the first video, that is pharmacokinetics, drug absorption. Thank you all.